I fully agree with what Tobias said. It's extremely helpful. It's non-toxic. It's generally reimbursed by insurance companies, and it can be extremely helpful. The other part of it is that it's often sort of group therapy. So when you go to pulmonary rehab, there are often other people going through the same process, maybe not all who are recovering from surgery or treatment for mesothelioma, but all who have some impairment in lung function. And there's some benefit to supporting each other during that process. So my patients who have gone through pulmonary rehab enjoy it. Part of it is gets them out of the house, and doing something and being active and being part of a community.
Maybe giving a little bit of a control back to a patient.
It's actually, and we are trying to expand this into mesothelioma. We actually have a very active program at our institution that's actually focusing on the rehab aspect, but then also of self-empowerment of patients, where you actually kind of take control of your disease and you actually actively are involved in the care, but also actively are involved in doing things in your activity during your daily life and activity of daily living. And that's actually been very helpful for other patient groups already. So we hope that this will also translate into help in the mesothelioma community. But for instance, the chronic obstructive pulmonary disease, it's actually been very helpful beyond just the physical exercise part of this.
And I'm also wondering, cough, chronic cough seems to be such a complaint in this community. Tricks of the trade, first of all, what is chronic cough? What is the cough? What are the underlying causes of a cough? And then maybe what are some of the remedies that are used? And I know I'm asking, it's a wide open, I know there's a lot of different reasons, but if you can go into some of the basics of what the most common causes of cough in a mesothelioma patient.
You have to understand that I think it's easier to treat mesothelioma than it is to treat chronic cough. Chronic cough is I think the most difficult diagnosis that a pulmonologist has, and we often dread when a patient comes in, especially when they've been through multiple other physicians first and then they come to you and they've an exhaustive workup. So in the context of mesothelioma, the chronic cough can be from a multitude of things, and it really depends whether they're newly presenting and there's a large pleural effusion, or whether they've had radiation therapy and there's radiation fibrosis, or they've had surgery and they're just recovering. So it really depends upon the context. But it can be a very difficult thing to treat, and there is no one drug to use. I think that one of the things that we'd like to avoid is over-medicating people with chronic cough. Narcotic medications are okay for treating chronic cough, but they over-sedate patients, and if you have marginal lung function because of underlying disease, including mesothelioma, and suppressing respiration is not a great idea, and it doesn't get at the root cause. Cough is extremely complex. In general, for patients who don't have mesothelioma, for patients who come to pulmonologists, the most common cause of chronic cough are postnasal drip, sinus disease, so nose and sinus disease, and reflux disease. So I think the first thing that we do, at least that I do when patients come to the office, is aggressively treat your postnasal drip and your esophageal reflux. And it may be that post-surgery, for example, in mesothelioma, your reflux may be worse. So you may need that more aggressively treated. So that's something that we can relatively easily do, although medication doesn't always fix the problem because it may be an anatomic issue. Your stomach may have moved up in the chest with your diaphragm after surgery, and that change of position may increase the amount of reflux that you have. Sinus disease and nasal disease are very, very common. And so treating that aggressively, getting ENT doctors involved if you have chronic sinus problems is also important. So I think I work on those. And then asthma is the other thing that we see. Asthma is a very common disease. Mesothelioma is rare, but there probably are many patients with mesothelioma who have underlying asthma who aren't being adequately treated. So I think the first three things that you treat are underlying asthma, postnasal drip, sinus disease, reflux disease. After that, you're getting into a very big gray zone of where other things can come into place. In terms of tricks, beyond that, there is some data using a drug called gabapentin or Neurontin that was recently published in the journal Lancet a couple of years ago for the refractory chronic cough. Again, this is a drug which is used for just about anything, chronic pain, seizures. It's been studied in chronic cough. I don't have a lot of experience with it, but it's something that I'm trying for my patients who are just not responding to anything else. And now I'm going to pass it to Tobias and see if he can enlighten me on what he does.
No, and I have to agree with Dan that in general, we also focus first on these three most common causes of chronic cough, and we make sure that since mesothelioma is a rare disease, common things being common, you still have to make sure that it's not one of these other three big players in the context of chronic cough. If that's not the case, the other important thing is to really make sure that the patients actually understand what cough means, and that cough actually serves a physiologic function, meaning clearing your airway, and that having the occasional cough is actually not necessarily a bad thing. So I really try to understand how debilitating cough is. If, of course, cough becomes debilitating to the degree that patients cannot go out and attend social functions and cannot sleep at night, these are the kinds of patients, if you don't find the cause of their cough, where you want to look for anything possible to try to alleviate it on an individualized basis, such as dealing with the pleural effusion very aggressively, or trying to eliminate other potential contributors. And if that's not the case, then we're pretty much down to symptomatic therapy. And Dan already pointed towards the gabapentin. Another thing that we've used on occasions, actually with quite some regularity, is actually just topical anesthesia, so nebulized lidocaine, to basically provide a numbing effect in the posterior throat, in the back of the throat, to try to break the cycle of coughing and trying to make people more comfortable. But similar to what Dan was saying, the problems with opiates, obviously opiates like morphine and other opiates, they suppress cough at a central level, at the brain level. And in this context, they can make people drowsy and can make people difficult to function during the day. Lidocaine doesn't do that, but of course lidocaine, if you numb up the back of your throat, it's pretty much like going to the dentist, and it becomes very hard to eat and drink after that, and without getting things down the wrong pipe and aspirating. So all of these things have their pros and cons, and if you don't find any of these big three causes, you're pretty much stuck trying to individualize therapy as much as possible after you determine that this patient really needs some help with the cough.
Oh, so I'm hearing vaporize, I'm thinking about medical marijuana now. So what about, people who are giving prescriptions for medical marijuana who have one lung or compromised lungs? How does inhaling these type of substances, does it affect the lungs? Does it hurt breathing?
To be honest, I don't have a lot of experience with that, so I guess in the state where I'm practicing, there's I don't think I think there's a way to get medical marijuana. It's not been really in my practice that much. I don't think that it would have a very detrimental effect on the lungs theoretically, but
it's important to understand that you don't have to smoke medical marijuana. That medical marijuana comes in a liquid form that can be put in foodstuffs, and that's how it's often taken. So it's hard to recommend someone who has underlying lung disease to smoke something that's going to make them feel better. They can take the same substance orally without injuring their lungs, because even though medical marijuana has clinical benefits, there are downsides to the lung to smoking marijuana, which are well proven. So I would recommend that if someone was prescribed, if they lived in a state where medical marijuana was legal, that they get the oral form. However, it is best administered, and not smoke the drug.
So Dr. Sturman, I'd be remiss if I didn't ask you about what's happening with your gene therapy trials, because I know you've been championing gene therapy for so many years. Where are we with those trials now?
Thank you for asking, Mary. We appreciate it. So we just completed, is that 5 minutes to go? Okay. Thank you, Melinda. That wasn't a 5 out of 10 for our performance so far?
That was 5 more questions.
Okay. I thought we were on a 5. I thought we were up at least 8.5. We're doing really well. So we completed at the University of Pennsylvania I think the largest gene therapy trial ever in mesothelioma just this past fall. When I say completed, we enrolled the last patient. We're still following many of the patients in the clinic. And this was 40 patients, started in March of 2011. We finished in 3 years. We're summarizing our data, and we'll be submitting it, presenting it at the International Mesothelioma Interest Group meeting this fall in Cape Town, South Africa, and hopefully also submitting for publication or at the same time frame. So what we did was take a drug, which is a virus, a virus that causes the common cold. and this virus has been modified so that it can't cause illness in human beings, but it carries the gene for human interferon alpha. And this gene gets inside cancer cells and causes cancer cells to produce the interferon alpha within the tumor cells themselves and stimulates the body's immune system to recognize and start to fight the cancer. And we give this together with standard of care chemotherapy, both in the front line with pemetrexed and in the second line with gemcitabine. And so the study is stratified between front line and second line patients. And particularly in the second line, we appear to be seeing a significant signal in terms of benefit, in terms of long-term survival. So we hope to analyze all of our data in the next few weeks, submit our abstract to IMIG and submit our paper, but also we are in the planning stages right now for the next phases of clinical trials, including what we hope would be a multi-center randomized clinical trial in the second line between gemcitabine-based chemotherapy versus gemcitabine-based chemotherapy with the gene therapy combination. So we're very excited. We're not enrolling patients currently because we're trying to decide which direction to go in, and we hope to be restarted relatively soon.
That's great. So when you do disclose the results, I know that we'd be very interested to get it out to the community. Thank you. I have one question that came from the audience. It's sort of taking us a little off track, but do you see any late effects of radiation? So in other words, not in the immediate time period after radiation, but maybe years later, do you see any long-lasting or any new side effects that develop over time?
And yeah, with the acute radiation pneumonitis is what we discussed, but there is radiation fibrosis, like Dan pointed out, and this radiation fibrosis in some patients actually can be progressive and can basically cause progressive scarring of the lung, which then presents as more of an interstitial lung disease that can limit the breathing capacity of these patients. And the same is true for some of the other organs that specifically, for instance, the pericardium, the sac in which the heart is basically enclosed in, that late effects of radiation could be scarring of the sac, which can then limit the ability of the heart to expand and basically perform its pump function. So these later scarring effects can actually occur and can be quite debilitating, but unfortunately they're actually relatively rare, and they don't occur with a very high frequency.
I would just add one other side effect, late side effect of radiation that we see, which is not well described in the medical literature, which is radiation bronchitis, is what I call it, for want of a better term in the medical literature. When you give radiation and the central airways are in the field, on occasion they can become chronically inflamed and scarred. They don't clear mucus normally. Patients can be susceptible to recurrent infection. They may cough up a small amount of blood periodically. They may have a shorter breath. They may have wheezing. And this is a phenomenon that's very difficult to treat, and it's in the spectrum of chronic cough that you would see in those patients who've had radiation therapy. And it can be very debilitating. And one of the things that I use actually is what Tobias recommended, which is nebulized lidocaine. I find it very beneficial for the patients with radiation bronchitis.
Thank you. So I guess we're getting ready to conclude. Is there anything that you'd like to add that we didn't bring up in the discussion that you think might be important to share with the patients?
I think, just to summarize things, in my mind, the most important thing is really to take this team approach actually between all of us, all the specialties that I mentioned, but then also the patients. So I think it's actually very important for us to get you guys all involved and be active, and that the best outcome and the most credit, a lot of credit actually goes to the patient being actively involved in this process and helping to get better.
I just want to say thank you for having me here. It's always an incredible honor to be part of this very unique meeting, being together with patients, family members, loved ones, significant others, advocates, industry, scientists. It really is an incredible experience for me, and I renew this experience every time I come back here, and it gives me great faith that we're together going to get an answer for this disease. So thank you for having me.
Thank you.